a great morning ahead planned with two hematology topics. So first, we're going to be starting off with transfusion medicine with Dr. Rida Hasan, who works with the Transfusion Services Lab. And so I am going to pass off to Dr. Hassan.
Hi, good morning, everyone. All right. I am one of the new transfusion attendings, and I wanted to talk to you guys briefly about transfusion medicine. So this is just going to be like a basic overview of some of the important calls that you guys get from our end, where you're not sure why we're calling you when you haven't consulted us, and why we're screening your orders so closely. But yeah, so feel free to ask questions if you have them. I'm happy to stop and answer questions. And then just some of the objectives is that I hope after this talk, you guys will be able to recognize what some of the red cell transfusion indices are for various patient populations, and then understand cross-match versus uncross-match blood products, what the risks and benefits of each of them are. Understand how to activate a massive transfusion protocol, and identify common transfusion reactions that you'll see not only in oncology, but also in other patients. And specifically, we'll talk about taco versus trolley, since that's an important topic for your boards. All right, so this lecture is going to be in 3 different parts. And then the part 2 and 3 will talk about a specific case. And in order to make this interactive, I am going to have you guys say yes or no to specific questions, and feel free if you're yes, just put up, like, if you guys have seen the reactions tab on your Zoom, you can put in like a check mark, like you can check green sign, you can do clapping, you can do a thumbs up, and if you're not in agreement that you wouldn't transfuse this patient, then you can do the X sign, so we can just get an idea of how many people would transfuse or wouldn't transfuse, or what your thoughts are on specific patients. All right, let's get started. So for the first part, we are going to talk about which of these patients needs a red cell transfusion. So we'll go through each patient individually, but I just want you to think about this for a minute. The first one is a 50-year-old male. He's in the ICU with pneumonia. He's on a ventilator on stable settings. His hemoglobin is 7.1. The second one is a 45-year-old male with alcoholic cirrhosis who has an upper GI bleed. And his hemoglobin is 7.3. Hematocrit is 22. And the third one is a 63-year-old female with AML who's admitted for induction therapy, and her hemoglobin is 8 and her platelet count is 4,000. So as you're thinking through those patients, I just want to take a few minutes to talk about, I know this seems basic, but what are some of the risks and benefits of a transfusion? So what are some benefits of a transfusion that you can think of in a patient? And this part you might have to just unmute yourself or put it in the chat. Let's get at least like 1 or 2 answers.
So someone in the chat said makes people feel better.
Okay, so quality of life actually is a huge thing, especially when you're talking about oncology patients. So
and then another vote for improved oxygen carrying capacity.
Awesome. Oops. I don't know why this, I guess you can only put 1 in each one. Huh. Okay. And then some of the, so what are some of the risks of a transfusion?
So I think we're getting a lot of comments on volume. So can be positive or a negative with the risk of volume overload.
Mm-hmm.
Transfusion reactions.
Yeah.
Dr. Trolley.
Perfect. Okay. So that's pretty good. So yeah, you guys are probably pretty familiar with this at this point in your residency, but yeah. So the indications for a transfusion is really to restore blood volume in situations where you have acute rapid blood loss. And the other big indication is to improve oxygen carrying capacity. You can always consider, and I think it's important to discuss with patients when you're talking about transfusion, that, hey, if we don't transfuse, how we think that maybe it could be more symptomatic or what the harms of it could be. And the risks, you guys got it right there. Transfusion reactions being the biggest risk. We see volume overload, fevers, febrile non-hemolytic transfusion reactions, septic transfusion reactions. So our products are good, but they're not perfect. They can always be contaminated. And then transfusion transmitted infections are also a big thing that patients worry about. And I'd love to tell you that the incidence of this is 0, but even with all of the testing that we have implicated today, it's still not quite there. So HIV, there's still like 1 in a million chances. It's very low, but it is a chance that you could get HIV through a transfusion. Hepatitis B actually is the highest risk. And then bacterial contamination, like I said, is actually even more common than these viruses. So platelets are much more likely to be contaminated than red cells, and that's because they're stored at room temperature. And red cells are stored in the fridge, but they're still pretty high risk of that. Allergic reactions, something as severe as anaphylaxis, although it's rare. And then the thing that we worry about as blood bankers is being alloimmunized to red cell antigen. So if you're exposed to an antigen that you don't express, then you can potentially make antibodies against it. All right, guys, yes or no, would you transfuse this patient? He's a 50-year-old male admitted to the ICU with pneumonia. He's on a ventilator and his hemoglobin is 7.1. I see one no. What would you guys do? Couple of no's. Okay. All right. There's people that might transfuse. Oh no, that's a no. Okay, perfect. Yeah, so our transfusion thresholds are actually based on specific guidelines. So people actually did studies where they looked at whether or not you transfuse at certain parameters, how these patients do. So the biggest trial for the ICU patients is the TRIC trial, or transfusion requirements in critical care. So for this patients, essentially what they did was they assigned patients in the ICU, so they could be on a ventilator. They did have to be stable from specific parameters, but they were allowed to be on respiratory support. And they assigned them either to a restrictive group or a liberal group. So the restrictive group, the goal was to keep them over 7, anywhere between 7 to 9. And then the liberal group actually was to keep them over 10, which back in the day, that actually used to be the requirement for some patients. This was a pretty large scale study. It was published in the New England Journal of Medicine. And you can see that obviously the restrictive group was likely to be transfused. That makes sense. Hospital mortality was actually a little bit lower in the restrictive group, and this was just barely significant. 30-day mortality seemed to be lower, but this wasn't significant. And then also the restrictive group was a little bit less likely to have multiple organ dysfunction based on the scoring system that they used. The other thing they looked at was the Apache score. So this is like a severity of illness in the ICU. So patients who were less sick did better in the restrictive group in terms of 30-day mortality as compared to patients who were liberally transfused, and also younger patients. So patients who were less than 55 years old did much better than patients who were liberally transfused. They found that for cardiovascular disease, there really wasn't a significant difference in mortality at 30 days between restrictive or liberal. And there's actually some other studies to suggest that these patients actually don't do as well with the restrictive transfusions. And this was just in 1999, but there have been a lot of studies since then that have actually looked at similar 30-day mortality using lower hemoglobin threshold versus higher hemoglobin threshold. And they've similarly, most of them have found it, again, using a lower hemoglobin threshold is better for this patient population. All right, so you guys got it right there. So this patient, he's stable, he's in the ICU. TRIC trial, you can probably keep him above 7, just with how he looks clinically right now. It's okay that he's on respiratory support. You don't have to transfuse, you can observe the patient. I see the answers already right there, but if the patient was in the cardiac ICU and he was admitted for something like a myocardial infarction, there's actually not enough evidence to support a lower threshold for these patients. So most people will use a threshold of 8 or higher. And that's kind of where we've been, and we haven't had any studies that have shown that lower thresholds are necessarily better for these patients, even though they're a little bit higher risk for volume overload. Okay, so this is your next case. It's a 45-year-old male. He has alcoholic cirrhosis, class B, and then he's coming in for an upper GI bleed, and his hemoglobin is 7.3. I'm seeing a couple of no's. Okay. Yeah, I see a couple of people saying no, they wouldn't transfuse. Some people might. So there actually was a study that looked specifically at transfusion strategies for upper GI bleeds. And this one looked at, again, a restrictive versus a liberal threshold. It was a randomized control trial in the New England Journal of Medicine, and pretty large scale study. They used a threshold of 7 for the restrictive group and 9 for the liberal group. And what they found is that the restrictive group, both groups actually did fairly well with over 95% survival, over 90% survival, but the restrictive group did do a little bit better, and this was statistically significant. And in terms of future bleeding, the restrictive group was actually less likely to have further bleeding as opposed to the liberal group that had more rebleeding episodes. And this was actually thought to be due to the increased portal pressure gradient that you cause, especially if they have like hepatic failure in this patient population. So one of the things they also looked at was they stratified these patients based on the presence or absence of liver cirrhosis. And an interesting finding is that really if your patient's liver failure isn't too bad, so if they're Child-Pugh class A or B, then they actually do value, they actually do better with a restrictive strategy. But if they're class C, then these patients don't necessarily do better with restrictive versus liberal. So if this patient was class C, then you might actually be okay with transfusing, as opposed to if he's class B, you could probably hold off. All right. So for this patient, his hemoglobin, a hemoglobin threshold of 7 is associated with possibly a decreased mortality, lower rates of rebleeding, given that he's class B. So you could hold off on transfusing if he's otherwise hemodynamically stable. All right. This is probably the most controversial because it varies from institution to institution. But you have a 69-year-old female with AML who's admitted for induction therapy. Her hemoglobin is 8, her hematocrit is 24%, platelets are 4, she's going to get platelets too. Would you transfuse, yes or no? Okay. I'm seeing a mix of answers. Some people would and other people wouldn't. And I have to say, there's no right answer for this patient population. So there was this trial called the Plato Trial. It was actually published. Some of the people were based out of here. It was one of the biggest trials that looked at platelet transfusions in the hemonc population. And they specifically looked at transplant patients, patients on chemotherapy, both solid and liquid tumors, and they assigned them to different doses of platelets. But that's not the point of our study. And one of the sub-analyses that they did following up to the study is that they found that patients who have thrombocytopenia are more likely to bleed, and obviously that makes sense. But this occurs despite despite them getting platelet transfusion. So even if you transfuse them, they don't necessarily bleed less. And the highest was in patients who are less than 5,000 for their platelet count, which is expected. But even patients with platelet counts of anywhere between 6,000 to 80,000 still actually had a little bit higher risk of bleeding compared to patients who had higher platelet counts. And some of the subgroups that they found is that obviously if your patient has abnormal coags, they're a little bit higher risk of bleeding, but then also having a lower hematocrit puts you at higher risk for bleeding. So the specific threshold they used was 25 in their study, but different studies have looked at different hematocrit thresholds. And I think this picture visualizes this really well. So this shows the effects of hematocrit on platelet deposition on damaged arterial segments. So you can see here on the bottom, if your patient has a hematocrit of 40 and they don't have enough platelets, they're not going to be able to form a good clot. If you increase just their platelets but decrease their hematocrit, their clot forming ability really isn't still that great just by increasing the platelet count. However, if you increase both their hematocrit and their platelet count, you can see that they're able to form much larger clots. And It's because there's interactions of red cells with platelets. So you need red cells and platelets to help form a clot. And it actually, the presence of red cells will actually enhance the platelet function. And there's even thought to be a little bit of like a structural component where if you have more red cells, it helps pull the platelets out to the periphery where they're able to bind to your endothelium a little bit better. And that's all important for normal hemostasis. So red cells are involved in the formation of the platelet plug. And some studies have shown that the time to bleeding can actually be decreased for each increase in hemoglobin that you have in this patient population. So this is where it's a little bit controversial, but here at this institution, especially if they're being followed by the SCCA, given that this patient, although her hemoglobin is an 8, given that her platelet count is also low, they would actually consider transfusing to keep hematocrit over 25%. And how many of you have seen that on your onc rotations, hematocrit goals of 26%? I think a couple of you. So that's kind of where the theory comes from. I think the evidence is still pretty soft, and you might go to another institution that doesn't do that. But that's what the thought is behind all of it. So essentially, just in summary, anemia and thrombocytopenia are not the same in all clinical settings. You really have to look at what the patient's clinical status is and what their underlying illness is.
There were 2 questions in the chat I just wanted to raise. So one was when we were talking about our critically ill patient with pneumonia, and wondering if there were any trials looking at even lower thresholds, so such as like hemoglobin of 6 versus 7, if that's ever been studied. And then a second question about patients with coronary disease. What are there different transfusion thresholds for patients with stable, severe, like coronary artery disease, or is it only for an acute MI that you would kind of raise your threshold to 8?
Yeah. So for the lower thresholds in the ICU patients, I actually haven't come across those studies. I think 7 is the lowest I've seen, but I can take a look to see if there's anything. But most studies looked at like 7 versus 9 or 7 versus 10. And then in terms of the stable cardiac patients, that actually, so there's been a lot of studies looking at transfusions in cardiac patients, and the findings have been all over the place. So there's really no good consensus about what the thresholds for these patients should be, especially if they're otherwise like stable and outpatient, and they're being followed as an outpatient setting. Like there's really not a good consensus. It kind of just varies on the clinician. So unfortunately, I don't have, it's not as much, it's not as consensus as I'd want it to be, but yeah, most people right now will use thresholds of 8, but I've also seen people use 10. I know sometimes the cardiac ICU uses 9. So it's been shown that using lower thresholds is not necessarily helpful for these patients. Yeah. All right. And then, so for this question, it's a 50-year-old male who's admitted to the ICU with pneumonia, who's on a ventilator. So going back to kind of our first case. So how many units do you transfuse this patient? So his weight is 70 kilos. He's like an average size male. How many people say 1 unit is fine? All right, I'm getting a couple of guesses. How many people would do at least 2? Okay. 3 units. And 4 units. I think some people's check marks are just there permanently, so I don't know. But yeah, so have you guys heard of the ASH Choosing Wisely campaign? Some of you are nodding your heads. So basically, it's a series of recommendations that came in terms of helping with our practices on when to like order specific tests, and when there's also transfusion guidelines in there a little bit on when to transfuse patients and how much to transfuse. So essentially, they recommend that you shouldn't be transfusing more than the minimum number of red cell units necessary to relieve symptoms of anemia, and to return to a patient to a safe hemoglobin. So this patient's 6.5, you're probably trying to get them closer to like 7, a little bit higher than 7. So you should really be transfusing the smallest effective dose, because liberal transfusion strategies don't necessarily improve outcomes. And So clinicians in general, they say avoid transfusing 2 units when just one could be due. One could be enough to bring them above the threshold. So in this patient, I would probably just say that 1 is fine. But I think I've seen a lot of people who would order 2. And one of the things to consider is also if they're an outpatient and how frequently you're having to bring them into the hospital. But that's kind of what the guidelines recommend. All right, we'll go to our second case. Okay. All right, so this is just going to be a case. So basically, you have a 45-year-old male. He's coming in with an upper GI bleed. His initial hemoglobin is 7.3. He's sitting in the ED. You're doing your evaluation. You're calling GI. And then after 2 hours, you repeat his labs, and his hemoglobin is 6.8 now. It's dropped a little bit, but hemodynamically, he remains pretty stable. And then you're worried that his hemoglobin dropped 0.5 gram since he's been here, that maybe he's having ongoing bleeding, and you're not sure what to do next. So at this point, you have 3 options. You can obtain a type and screen and order 1 unit of cross-matched red cells. Or you can order 2 units of emergency uncross-matched blood or red cells from the transfusion services, or you can activate a massive transfusion protocol. So how many of you would do the first one, which is obtain a type and screen and order 1 unit of cross-matched red cells? Seeing a couple of yeses. Okay. How many of you would say, no way, this patient's hemoglobin is dropping way too quickly. I would order 2 units of emergency and cross-matched blood. I think there's some people that would do that. And then how many of you would activate the massive transfusion protocol? Okay. All right. So when you're obtaining a type and screen, there's a couple of things that we're looking at. So the first thing that we're looking at is the patient's blood type. And there actually is a method to doing it. So what we do is we do this in 2 parts. We do something called a forward type, and then and that helps us determine what antigens are present on the patient's red cells. And then we do something called the reverse type, where we look to see what antibodies are present in the plasma. So what we need in order to know your blood type is actually, it should match up perfectly. So if your forward type shows us that you have an A antigen on your red cell, then when we look in your plasma, we should see the presence of anti-B, and that'll tell us that, okay, you're definitely blood group A. However, if you are forwarding and we see that you have an A antigen on your red cells, but then we don't see any antibodies in your plasma, then that actually leads to what we call like an ABO discrepancy, which can take a little bit longer for us to work up and figure out, why do you not have any antibodies in your plasma? What is your real blood type? Are you type A? Are you type AB? We don't really know, and we want to be able to give you safe products. So that part itself actually doesn't take too long. The part that takes a little bit longer is the screen. So the screen is a completely separate test. And what we're doing is we're taking the patient's plasma and we're looking for the presence of unexpected antibodies. So these are not like anti-A or anti-B, because that's something we all make naturally, but it's specifically against some of your other blood groups like your Duffy, Kel, Kid. And we expect that most people are not going to have these antibodies, and they're what we call not naturally occurring. But if you've been transfused, or if you've been exposed or pregnant in the past, then you could potentially develop these antibodies, and they can cause hemolytic transfusion reactions too. So that's why we recommend that these need to be screened. Type and screens are repeated every 72 hours, essentially to look for the presence of these antibodies. And the type and screen, really the screen part is what takes us a little bit longer. And it takes about like 30 minutes to 40 minutes for us to actually do it from the time that we get the sample. And the other thing that we do is, if we've never seen the patient before, we actually ask for 2 samples up front. And if you've seen the order for like 1 type and screen and a confirmatory. And that was more so to prevent errors with wrong blood in tubes. So sometimes people would mislabel a specimen, or you think you're with a specific patient and you have their blood, but it was really another patient. So to avoid problems with ABO compatibility. So we do have specific turnaround times that we aim for. So if you order a routine type and screen, and then you're ordering blood products, Your turnaround time could be anywhere up to 4 hours. If you order it stat, but you want it cross-matched, if the patient has a current type and screen, it's going to take us about 30 minutes to get you the product. And then if you are ordering it and we don't have a type and screen and we have to run that along with it, that'll take us about an hour to get you the blood products. If you do emergency release on cross-matched products, you can see that it's a lot quicker. So red cells will take us about 5 minutes, plasma and platelets about 10, and cryo about 20, because we have to thaw it from the freezer. So what are some risks and benefits of giving the emergency on cross-matched units that you can think of? So what are some good things about giving emergency on cross-match units?
So faster, I'm seeing that in the chat. And then risk of trans reactions.
So yeah, it's one of the risks, I would say, risk of reactions. Yeah, so those are two big things that we think about. So yeah, the risks, some of the benefits are that you're going to have a quicker turnaround time. All of our emergency on cross-match products is going to be type O. So you think for red cells, it's different for plasma products, but you think that, type O is a universal donor, so you're not going to have any kind of ABO incompatibility and you should be fine. We actually give type O positive for most of our patient populations, and we'll save O negative specifically for women who are of childbearing age, and we'll talk a little bit about that in our transplant population. And then the risks is that, yeah, you could have allergic reactions, but also you haven't done the patient screen. I don't know if this patient has any kind of underlying alloantibodies. So I could potentially be exposing him to some antigen he has an antibody against, and he could be at risk for having a delayed hemolytic transfusion reaction. And then the other risk is that I don't know if the patient's Rh positive or negative. So if it's a male and I'm giving him Rh positive products, potentially I could expose him to the D antigen and he could make an alloantibody against D later. So in this patient, not that this is the right thing to do, I think it's debatable whether you think the patient's stable enough to wait to get a full type and screen and wait about an hour, or if you think that you could need emergency on cross-match products right away. It would have to be based on the clinical scenario. But you decide to go ahead and give one on cross-matched unit, and then you have to order a type and screen, because even if you're giving on cross-match, we still ask you for a type and screen because we want to be able to make sure that whatever product he's continuing to receive are compatible. And the patient comes back. And so the unit he got was O positive. His blood type comes back as O negative, and his screen is actually positive, and he has an anti-Cal antibody. So what are you more worried about? So how many people are worried because they gave an O positive red cell to an O negative patient? If that's your bigger worry? And then how many people are more worried about the fact that you gave uncross-matched red cells to a patient who has a positive screen? Okay, I see a couple of people who are more worried about the second scenario. Yeah, so Rh positive transfusions and Rh negative patients. Like I talked about, this actually happens pretty frequently, especially, do you guys rotate through Harborview? You do, okay. So all the time at Harborview, this happens. So just so you know, blood type O is the universal donor. So that's about 45% of your population is type O. And just looking at Rh in general, so about 15% of us are going to be Rh negative and about 85% are going to be Rh positive. So if I have 100 units on my shelf, the probability of me having an O positive unit is essentially, I just multiply the probabilities together. So about 38 of my 100 units are going to be O positive. And in terms of O negative, about 6 of my 100 units are going to be O negative. So there's no way that every patient who comes in at Harborview without a type and screen, I'm going to be able to give O negative units to maintain my inventory. There's just absolutely no way. So what we do is we actually will give O positive as a standard up front. The only people that we save O negative units for are women of childbearing age, and that's because if they develop an anti-D, they're at risk for hemolytic disease of the fetus and newborn. And then also with neonates who they develop an anti-D, potentially it's going to be lifelong and could also cause hemolysis. So if someone gets a red cell transfusion, so if they're Rh positive, sorry, if the patient is Rh negative and they get Rh positive red cell transfusion, there's about a 25% chance that they're actually going to develop an anti-D. So most of these patients we've realized actually don't develop an anti-D, especially if you're transfusing in like a trauma or an urgent care setting. And this doesn't happen until you're kind of repeating their type in screens and they're staying in the hospital. And you'll finally detect it at some point on a repeat type in screen. It might even be months later. And with the initial event, there's usually no symptoms with the initial alloimmunization event by the time they develop the anti-D. But sometimes if there are some remaining transfused cells that are still in the patient when they develop it, you actually can have hemolysis of those transfused red cells. But usually it's pretty mild with the initial presentation. The other thing is with platelets. So our platelet inventory is also pretty limited. So we're giving a lot of Rh positive units up front. So if a patient is Rh negative and they get an Rh positive platelet, I want you guys to know that platelets don't express Rh. And we call you guys about this all the time. So platelets do not express Rh, but they can have red cell contamination. So the red cells are what express Rh. And back in the day, even up till last year, we actually used to do random donor platelets in which when you go in and give a whole blood donation, you could pool 6 donors together, you create a platelet unit that way. And the risk of red cell contamination was pretty high in those units. But now the way that we're collecting platelets is by apheresis, and the amount of red cells you have is significantly lower. So with platelets, your risk of anti-D, and there's lots of numbers reported in the literature, but your risk of forming an anti-D is a lot lower. It's about 1.44%. So this happens all the time. Your risk is extremely low. We have a lot of Rh negative platelet shortages. And what we'll routinely do is we will substitute Rh positive platelets for Rh negative patients. Have you guys ever gotten that phone call from the blood bank? Does it sound familiar? Okay. Yeah, so we'll call you guys and we'll say, hey, your patient is Rh negative. We're having a platelet shortage and we're going to give them an Rh positive unit. And then we'll tell you whether or not we think it's worth giving the patient RhoGAM to prevent anti-D alloimmunization. And I usually don't recommend it unless the patient is a female of childbearing age, unless it's a pediatric or a neonatal patient, or if it's a transplant patient who, if they form an anti-D, could decreases their risk of what their donors are for transplant. So oncology patients, a lot of them will do the same thing. We'll try to give them RhoGAM to prevent anti-D alloimmunization. And then the second scenario is actually the more scary one. So for the most part, he was exposed to Rh positive red cells. I'm actually less worried about that. I would just say monitor the patient and then know that he could possibly have a positive screen later. For the second scenario, the fact that he has an anti-Cal antibody and then you potentially transfuse units that are positive for Cal, he's actually at risk for a delayed hemolytic transfusion reaction. So this is a much bigger risk. He's going to have signs of extravascular hemolysis. His hemoglobin is going to downtrend to what it was before you transfused him, and he'll also have hyperbilirubinemia. Sometimes you can also see signs of like elevated LDH, low haptoglobin. And then rarely, but there are some antibodies that can actually cause intravascular hemolysis. So even though we're giving type O blood, I don't know what the Cal expression or the other allo antibodies are on that red cell. So potentially your patient could be at risk for intravascular hemolysis. All right, so going back to this case. So he's a 45-year-old male, GI bleed. You transfuse that 1 unit of uncross-matched blood, and now he has a large episode of hematemesis. All of a sudden, he's becoming hypotensive, tachycardic. You repeat his hemoglobin. This is all in the ER, and now it's 4.3. What is your next step? So how many people would order another 2 units of red cells? How many people would order another 4 units of red cells? All right. How many people would activate a massive transfusion protocol? Seeing a couple of yeses for that. And how many people would just order a stat CBC and coagulation studies? Okay. So some people might do that too. So whenever your patient has massive bleeding, especially in the setting of trauma, this actually predisposes you to a coagulopathy. So your blood, when you're coagulopathic, you have increased lactic acidosis. So when you're acidotic, your coagulation factors don't work as well. You also have a lower body temperature, so hypothermia. Your coagulation factors don't like that either. And then in terms of that, you just have what we call this trauma of triad that leads to increased risk of bleeding in a patient who's already having trauma. And then most people think that if your patient's bleeding, what am I going to give them? I'm going to give them blood because that's what they're losing. So you resuscitate with red cells, and that's great. But red cells don't actually have any coagulation factors in them. So while you're resuscitating them with just 3 or 4 units of red cells, realize that you're also diluting out their coagulation factors, causing them to be hypothermic, which is going to make their coag factors work even less and potentially put them in a worsening coagulopathy, and they're going to bleed even more, and you're going to give more red cells. So this becomes a really vicious cycle. So the whole idea behind a massive transfusion protocol is to really give plasma and red cells back in a 1-to-1 ratio, and kind of just give it up front rather than having to think about it and order it separately. So when do you activate a massive transfusion protocol? So we have specific criteria that defines what a massive transfusion is. And it's something as specific as 6 red cells in 3 hours, 10 red cells in 24 hours, needing more than 3 components within an hour. But I can tell you right now that when your patient's in the ER, you guys don't have time for this. Like, you're not going to see how many transfusion he needs in 3 hours to decide whether or not to activate it. So really, if your patient has 2 things that affect their ABC score, or if they have any kind of hemodynamic instability and in the setting of having a large bleed, then it's okay to activate a massive transfusion protocol. You do not have to wait for all of these parameters or any of these specific parameters to be met. And how many of you have activated an MTP before? Can I get a thumbs up if you've done it? No. Okay, some people have. Yeah, so activating an MTP, we try to make it as easy for you guys as possible. So all you have to do is call the blood bank and say, I need an MTP. Tell us the patient's name and MRN, where they are located, what your name is, and who's the contact person. And what we're going to do is we're going to give you what we call an MCP pack. So this is going to give you, so we don't really do a la carte MTPs. We try to discourage that, where you're saying, oh, I want 2 red cells, 3 plasma. We'll give you a specific MCP pack that will have certain products in it and send it to you right away. And you can decide whether or not you want to transfuse what products. So it'll have 4 red cells to 4 plasma, and then you can additionally request if you want platelets and cryo. We do not give it up front. And that's because there was a lot of wastage with that previously when we were including it up front. So that is something that we might ask you, like, oh, do you want platelets and cryo? Or you might have to specifically mention, but if you don't talk about it, realize you're not going to get platelets and cryo with your MTP pack. And then the other, and I think just as important part of an MTP pack is, of the MTP, is getting an emergency hemostasis panel. So when you're resuscitating these patients with these large volume transfusions, you're making them more coagulopathic. So you need something to be able to guide how quickly are you transfusing them? Like, do they need, how do you know if they need cryo? You don't know what their fibrinogen is. So there's something called an emergency hemostasis panel that's available. And what it does is it looks specifically at your hematocrit, platelet count, fibrinogen, and INR. This is a lot of information in one slide, but it essentially goes through what I already talked about. And the way that we sent the pack, the Mcp pack to you, actually is a little bit unusual. So we'll tube down 2 red cells right away to where you are. So if we know you're in the ER in a specific room, or if you're in the OR for whatever reason, but we will tube down 2 red cells to the nearest station to you. And then the rest of the products we actually send down in a fridge. So the other red cells and plasma will come down in a fridge. So the turnaround time for the first 2 red cells is actually pretty quick. It's about 5 to 7 minutes. That's our goal. The second 2 red cells and the 4 plasma to get us the fridge to you actually takes us a little bit longer. It takes about 5 to 10 minutes. And then if you request it, platelets are actually available pretty quickly within 5 to 10 minutes. And then cryo is the one that actually it takes us a little bit longer to get to you because that's something we keep frozen on hand. So we have to thaw it. It takes about 20 to 30 minutes to get you a unit of cryo. And then with the emergency hemorrhage panel, so this is a lot different than you ordering just platelets. Some people will order like coags independently. They'll just order a stat CBC or stat PT, PTT. And it's actually a little bit different the way that the emergency hemorrhage panel is designed. So the lab is taught that when an emergency hemorrhage panel is ordered, they're going to stop everything else that they're doing and process this specific sample first. And that's what they're going to result before they go back to doing all of their other testing on top of and this includes statin routine orders too. And the other thing with the hemorrhage panel is that the way that we have our instruments set up to report these counts is a little bit different. So usually the machines that are reading your platelet count want to be really specific. They want you to know, oh, is your platelet count really 383 or is it 384? And it'll do all of these remeasurements to get you a specific number. But we realized that in an MTP setting, that doesn't matter. All you care about is if your platelet count is less than 100, or is it greater than 300? Do I need to give platelets? Do I not? So we actually have the instrument set up a little bit differently to not be as specific, but still give you a sense of where your patient's coagulopathy is. So the turnaround time is a lot quicker. And our goal is that really when you order it and you send it to the lab, we should be able to have results to you in about 15 to 20 minutes. And this is a lot faster than ordering a separate stat CBC, PT, PTT. And we expect that if the MTP is happening and you're transfusing all of this product to your patient, then you're going to keep repeating this actually every 30 minutes because obviously their coagulation status is changing over time. All right, does anybody have questions about that? Okay, all right. So I'll go over to the last case. This should be a little bit quicker, hopefully, but you have a 59-year-old female who has AML, and she's admitted for neutropenic fever and is receiving 1 unit of red cells. So while she's transfusing, her vitals are notable for a temp increase. So she goes from 37.0 to 38.5, and the rest of her vitals are stable. So you make a plan to go see the patient. But before you hang up, what is something that we always ask you to do whenever a patient has a fever during your transfusion? So you should absolutely.
Everybody in the chat saying, stop the transfusion.
Yes, perfect. So you should absolutely stop the transfusion immediately. So anytime a patient has anything that makes you worry about a transfusion reaction, please stop the transfusion. Do not worry about saving our products. We want the patient to be safe. And then the nurses are actually really great at doing a lot of this. So I don't know how involved you guys get with the whole transfusion reaction workup, but I do want you to be aware of what's happening in the background. So they will actually call the blood bank and say, I think this patient is having a transfusion reaction. They spiked a fever during a red cell transfusion. And what we ask them to do is actually return the entire unit with all the tubing attached back to the blood bank. And then we will ask the nurse to order a transfusion reaction workup, or possibly you guys are the ones putting in that order, I'm not sure. And then we also ask for a post-transfusion sample. Usually it's a purple tab. So what do we do when you report a transfusion reaction? So there's a couple of different steps that we take. The first one is that we do a clerical check. So this is our biggest fear did we get the right product to the right patient? So we double check that we have the patient's blood type, what the type of the product was it something that you expect to be ABO compatible? And this will help you potentially look for like acute hemolytic transfusion reaction. With the post-transfusion sample that you sent, what we can do is we can look for evidence of hemolysis. So all we do is spin down the sample and look to see if the plasma is red or not, and that'll tell us if there's hemolysis present. We'll also do a DAT, and that'll, again, help us look for things that might support like a hemolytic transfusion reaction. And then we might recheck the patient's ABO. And these are all things that'll help you diagnose an acute hemolytic transfusion reaction again. And then the other thing we do with the unit that you send back is that we can decide whether or not we need to culture it. Like we said, red cells and platelets, and even plasma and cryo, all of them have been implicated in septic reactions before. So we will decide whether or not to culture the unit. It's not necessarily I talk to the clinical team about, but if you guys have a strong suspicion that it was the unit that caused the fever and now the patient's septic, then we're happy to talk to you and decide to culture the unit together. So why would a patient have a fever during a transfusion? What's your differential? So this was the AML patient who was admitted for neutropenic fever. Non-hemolytic transfusion reaction. Yeah, what else is there? Let's get at least two more things. So outside of a febrile non-hemolytic transfusion reaction, because that's kind of a diagnosis of exclusion. Infection, yeah. Sepsis, perfect. I love that. Patient is sick at baseline. Yes, because most of these are on patients. So underlying disease. So the patient's already admitted for fever and neutropenia. Most of the time, that's probably going to be the cause if it's their underlying disease. Hemolytic transfusion reactions. So acute hemolytic transfusion reactions, if you give someone an ABO incompatible unit, the first sign you're going to see is fever in most of these cases. So that's something that we're very worried about. Bacterial contamination of the product. If it's a septic transfusion reaction, just becomes septic. Trolley also can present with fever. So not all of them, but most cases will present with some kind of fever. And then taco, we don't necessarily think of as having fever, but it actually has been shown that it can, in 1/3 of cases, present with fever. And it's something that they call hot taco. It's like the new terminology for it if you have fever with it. And then febrile non-hemolytic transfusion reactions, obviously, is something you guys are very familiar with at this point. So with the workup that we do, when you guys send us the samples and we do our compatibility check, is that we can pretty much rule out an acute hemolytic transfusion reaction. We can send it for a culture and we can make sure it's not a septic transfusion reaction, but everything else essentially becomes like a diagnosis of either exclusion or based on the patient's clinical scenario. And underlying disease is something we're not usually able to exclude. Taco trolley, I think usually rare, but taco actually is now the most common cause of transfusion-related mortality that we're seeing in patients, the most commonly reported. And then febrile non-hemolytic is the most common in general. So febrile non-hemolytic transfusion reactions are caused by cytokine production from donor leukocytes that are in the product that you're transfusing. And the symptoms that you see are usually fever, you can have chills and rigors, and you treat the patient by doing antipyretics. And there's a couple of ways we can prevent it. So the easiest way to prevent it is to just remove the white cells that are going to release your cytokines from the product. So we do something called leukoreduction, and that's actually done universally on all products that we have in the hospital. The other thing we advise, if it's a patient who's been in the hospital for a while and you can see that they're spiking fevers every day during certain times, kind of try to avoid starting a transfusion when they're going from like 37.5 to 38 and 38.3. And sometimes I understand you patients just constantly febrile, you have to start it when they have a fever. But if you can do it when their temperature is downtrending rather than uptrending, that's something that you can do. And then people always ask about this, why can't I just give Tylenol before as a pre-medication? There's actually not enough good literature out there that supports that giving Tylenol beforehand is going to prevent your patient from having a febrile non-hemolytic transfusion reaction. And then the other worry that we have is that if you mask a fever with this potentially, and maybe it is an ABO incompatible product, then you could potentially mask signs of hemolytic transfusion reaction. So we usually don't recommend doing pre-medication, but I know it, especially in the onc population, for some patients it works really well and for other patients it doesn't. But there's, in general in the literature, there's not enough evidence out there to support it. So let's say it's the same patient again. But this time when you're transfusing, they start complaining of chest pain and their oxygen saturation decreases from 99 to 100% on room air. So what is your differential for kind of respiratory distress during a transfusion? Let's get like maybe at least 2 answers in the chat box.
Volume overload, anaphylaxis. Yeah.
Perfect. Yeah, so differential, it's actually not too many things, but TACO is the biggest thing. Like I said, it's the most common now cause of transfusion-associated mortality. So it's fluid overload caused by the blood product. And then trolley is caused by, can be caused by different things, but the most common that we think about is HLA or HNA antibodies, human neutrophil antibodies that attack the patient's white cells. You can also have something called transfusion-associated dyspnea, which is essentially like a bucket term as a diagnosis of terminal exclusion. So if we don't think it's TACO or trolley, but the patient clearly had respiratory symptoms, then we could potentially group it in there. And then also allergic transfusion reactions can sometimes present with it, especially anaphylaxis, although they're extremely, extremely rare. A lot of people think about like IgA deficiency as causing like anaphylaxis, respiratory symptoms. There's actually evidence to show that most patients with IgA deficiency actually don't have anaphylaxis with blood transfusions when they're exposed, but that's a topic for another day. But that is something to think about. So TACO trolley, you get a chest x-ray, right? So what is this, TACO or trolley, can you tell? So this is actually TACO, according to the paper that I was looking at. And then this one is actually trolley. So you can see that it's really with x-rays, this is a very poor quality picture, but x-rays, it's not extremely clear between the two. So it's really hard to do it just based on x-ray findings on their own. You kind of have to look at the patient's entire clinical scenario. So TACO, you think about like a cardiogenic cause. So the patient has some kind of pulmonary hydrostatic edema, and essentially trolley is more of like a permeability edema. So you think more like inflammation, but both of them are thought to have like a 2-hit model. So the first hit is usually there's something with the patient. So not every patient you transfuse red cells, even if you transfuse it over an hour, is going to have TACO. So there's something with the patient's clinical condition that kind of sets them up. And then the second thing is when you actually transfuse the patient, there's something that activates a pathway that causes the actual symptoms. So for TACO, it could be the patient already has some kind of positive fluid balance, cardiac renal impairment. And then on top of that, you're giving suboptimal fluids, like a lot of transfusions really quickly, or it's just enough to tip them over the iceberg. And then trolley, they usually have some kind of baseline inflammation in their lungs. And then you're also introducing either these antibodies or some kind of biological response modifier that activates the neutrophils and causes the inflammation. So I think this is a really good visual that puts into perspective what the differences are between the two. So I'll just go through it one by one. So TACO, your first hit really is a patient who has volume overload, cardiac renal failure. And then the second hit is when you transfuse the product, then you cause like a hydrostatic cardiogenic edema. So you don't really expect there to be a ton of inflammation, but it's not actually inflammation is more important than we realized previously. But it's more so from like an increase in hydrostatic pressure. And there are certain cytokines that you expect to be increased in these patients. And then trolley is a little bit different. So your first hit is the patient's already inflamed, and it could be for a lot of different reasons. They're already on some kind of ventilator support. They have renal failure, older age, trauma, liver surgery. There's a lot of things that can put you at increased risk. But essentially, we think that your lungs are already primed with these neutrophils. And what happens with the second hit when you transfuse the product is that you have either HLA or HNA antibodies that will actually activate these neutrophils, bind and activate these neutrophils. Or it doesn't even have to be antibody mediated. There are like biological response modifiers that have been implicated that can activate these neutrophils and cause you to have increased permeability and essentially permeability edema. And again, you get increase in specific cytokines that you can see with that. So distinguishing the two is probably very difficult even for us blood bankers. And I've seen a lot of scenarios in which patients are suspected to have taco and trolley and the IC is working them up and no one notifies the blood bank. We love to be involved in these cases, especially if it's something related to a product they were transfused from the blood bank. So please call us and we're happy to help you kind of go through the differential. But in general, with taco, you expect the patient's going to have hypertension, and it's not always this easy. Trolley, you see more hypotension. Taco, again, signs of like increased pressure. So you see neck venous distension. You also see that they have an elevated BNP. Most patients in the hospital don't have a normal BNP to start with. So if the patient doesn't actually have a baseline, I don't know what to do with an elevated BNP in most of these patients when we get one. But we do expect that they're going to respond to diuretics. And then the way that we recommend treating it is to give slower transfusions. We can also take away some of the volume of the transfusions that we give and do volume reduction. For trolley, we expect more hypotension. Again, it can be antibody mediated, so we can actually work up the donor for the presence of these antibodies. So we think the antibodies are from the donor that are activating neutrophils within the patient. So it's not the patient necessarily that needs to be tested, it's the donor. So we talk to the blood bank and have the donor come in and get the specific testing. We expect that these patients are going to have a normal BNP, but again, if you're critically ill, you're in this hospital, you probably don't have a normal BNP to start with. And then trolley, in terms of how you treat it, it's really just supportive care. Most cases will actually improve on their own within like 96 hours. So we expect the patients to have decreased respiratory support and that it'll resolve and the edema will resolve. And the way that we prevent it is that we prevent people who are at high risk for having these antibodies. So usually these are females who have previously been pregnant because they've had alloimmunization, they've had that exposure event, and they're more likely to have HLA and HNA antibodies. So for the most part, we try to use only male plasma donors, or if we use females, we'll actually look for the presence of HLA and HNA antibodies. And once a donor is implicated as potentially causing trolley in a patient, that donor actually can't donate plasma products again. And of course, like I said, always report transfusion reactions and talk to us. We are here, we're 24/7. This is our number and we're always open. All right, any questions?
I had a quick question about neutropenic fever. I just came off the hemonc service and I heard someone say that when people are febrile, that you might raise their platelet threshold due to risk of bleeding when people are febrile. Is that true, not true?
That's not something I've come across, but if they're febrile, is it the thought that the platelets don't work as well? Was that the thought process behind it? Or potentially they're using platelets because just having a fever could increase your platelet consumption. So that's one of the things.
Maybe it was the latter, I forget, but okay.
Yeah, sometimes when we're working up why patients are not responding to platelet transfusions, we think about consumption, and on that differential is like patients who are septic or have a fever, they have increased platelet consumption.
And there was also a question in the chat about using hematocrit versus hemoglobin threshold.
Yeah.
And is this just institution or lab specific?
Yeah, so I didn't train here until last year. So I actually was the hematocrit is something that's new for me. I will say the literature that supports the thresholds that I talked about with the hematocrit is most of it is based off the trial that I was referring to. But there are other studies that use hemoglobin versus hematocrit. And I think the thought is that hematocrit captures maybe a little bit, like hemoglobin is better for oxygen carrying capacity, but hematocrit, if you're thinking about like kind of how the red cells and platelets are interacting together, and how they're interacting together, kind of what the hemostasis is in the vessels themselves, how much of your platelets are in the periphery, that your hematocrit might be a better predictor of that.
Okay.
But there are institutions out there that most places actually use hemoglobin. They don't use hematocrit thresholds. And there are also institutions that wouldn't transfuse that patient. So it is very institutional specific.
Awesome. Thank you so much, Dr. Hassan. I definitely learned a lot. I think this is extremely helpful. We will give everybody about a 10-minute break. So we'll come back at 10:12 to get started with our next section. And I do want you all to pull up the PDF that I sent out in the email yesterday, because we'll be using that for our next session. And